Our next speaker will be talking about the anesthetic management of COVID-19 patients in the operating room. It's Dr. Alain Beloy. Dr. Alain.
Thank you. And thank you for inviting me to this conference. So my name is Hélène Beloy. I am a professor and in charge of the resident program in anesthesiology, critical care, and perioperative medicine in Rennes, in France. So I'm going to try to be fast because I know we are running late. I'm going to show you the protocols that we put in place, that we printed, that everybody is following, physicians and paramedics in the OR for general anesthesia in this time of the COVID-19 crisis. So this protocol was elaborated following the national guidelines that are available and that were elaborated by our national society. And of course, they were provided with the input of experts on infectious disease like Pierre Tadevin, who talked to us before. So the general strategy for general anesthesia in COVID-19 patient is, first of all, we treat all patients who are suspected of COVID-19 as if they were tested positive for COVID-19. You also have to have in mind in your protocols that you have to deal with the potential risk of lacking anesthesia drugs. You have, of course, to protect the healthcare force, and the critical moments are intubation and mostly extubation. So for intubation and extubation, we follow these rules. We do intubation and extubation exclusively in the operating room. I don't know how you do it usually in your hospital, but in my hospital, we usually do extubation in post-anesthesia care unit by anesthesiologic nurses. And these days we have changed. We do extubation exclusively in the OR at the end of surgery. When we do intubation and extubation, there's only two persons in the room, the anesthesiologist and the nurse anesthesiologist, that's it. And these two persons are fully equipped with FFP2 or N95 mask. They have gloves, full disposable gowns or suits, glasses or a face shield. So we have face shield in the OR for emergencies, and we have plastic glasses in the OR for scheduled surgeries. And of course, a full hat. And there's one person that is immediately accessible on the outside of the room that can see us, and we can see that person if we have an urgent need. So yes, next slide. For intubation, so we do not ventilate the patient, and we do not use laryngeal mask during this whole time of the crisis of COVID-19. So in order to not ventilate the patient, we use fast-acting muscle relaxant like succinylcholine or rocuronium. This is the muscle relaxant we favor during this time. During the GA, we favor sevoflurane over propofol just to save the stock of propofol because there might be shortage of propofol. And each time you have to do any manipulation, you have to change the position of the patient. For example, you always stop the ventilator before you disconnect the tube to avoid any spreading of any particles in the room. And extubation is the most critical situation because it's when you can spread particles and potentially virus. So we antagonize the muscle relaxants that we've been using. And one more time, we always stop the ventilator before disconnecting the tube. There's only two persons in the room, the anesthesiologist and the nurse anesthetist, fully equipped. And after extubation, we immediately put a surgical mask on the patient. And if the patient needs oxygen at that time, we favor nasal administration, and we put the surgical mask on top of the nasal administration of oxygen. And that's it for me. Thank you.
Thank you so much, Dr. Alain. That's a really helpful and strong insight about just minimizing exposure and only having two individuals in the room upon extubation. So we have, I think that's actually everybody to wrap things up. Again, just as a reminder, we do have Q&A. The speakers are graciously answering those feverishly online. I'm going to hand it over to Larry, but just one question, just for clarification. Alan, you said that you're assuming every patient has COVID-19 and that you're not using LMA on any case for that matter. I just want to get confirmation. Is that true? And then Larry, I'll hand it off to you.
Yes, it's true. We are treating all patients. So we, of course, like Johan said, we deprogrammed a lot of scheduled surgery, but there's still some scheduled surgery that we have to do, for example, in a cancer patient. So we're still doing some scheduled surgery. And in those scheduled surgery or emergency surgery, we don't use any LMA since the beginning of this crisis. And we are doing the process that I showed you for intubation and extubation. We're following it for every patient. So we are treating everybody as if they were tested positive for COVID-19.
Thank you. Dr. Chu?
Yes, okay, thank you everyone, all of our speakers for the great presentations. We've had so many questions, we haven't been able to keep up, and we wanted to get the information out there for our online viewers. We will be summarizing the questions that have been answered by our speakers. 39 questions so far have been answered online through our Q&A mechanism. We will summarize that for our online viewers who will be watching this afterwards. Let me just ask a few questions following up on our most recent presentation. So, one of the concerns, and we see in our most recent poll that about, I believe, let's see here, 23% of our audience today are anesthesia attending. So I think that it is very relevant, this last presentation, to our audience about the intubation extubation process and reducing the viral load exposure. I wanted to ask a couple of questions related to that. I understand about limiting or eliminating the use of laryngeal mask airways. In China, in Taiwan, in Asia, they have used plastic drapes, placed them on top of the patient. The idea being that they're see-through and that they could trap any aerosolized, in any respiratory tract aerosols that could potentially carry viral particles during the intubation extubation process. Is that something that your hospital is doing or has tried, is the use of plastic drapes over the patient as you're instrumenting the airway?
No, because we don't have that. So no, we're actually not using that because we don't have that kind of equipment. So the only protection we put on, to be fair, we never had in the OR a patient that was hospitalized for COVID-19 and that needed surgery. So all the patients that we dealt with in the OR was our patients that are suspected or that we treat like they are COVID-19 positive. And so the only protection that we put on patient is a mask, like just a surgical mask. And but we don't use any specific plastic drape on the patient.
Okay, great, thank you for that. Second question, after, can you speak a little bit about flow rates, both particularly for, you mentioned you use nasal cannulas. Do you have a particular flow rate for that after extubation? Do you try to limit the flow rate of oxygen?
Yes. Why we try to do is that make sure as much as possible that the patient doesn't need any oxygen when we leave the OR, actually. So the vast majority of the time, the patient, after extubation, we wait another few minutes to be sure that the saturation is fine and the patient doesn't need any supplementation in oxygen. And we leave the OR with the patient wearing only the surgical mask. And most of the time, we don't need any supplementation in oxygen.
And could you speak a little bit to your hospital policy regarding monitored anesthesia care, moderate sedation, or regional anesthesia cases? Is this something that you're trying to avoid right now? Or if you do these cases, what aspects or strategies do you use to manage any aerosol control?
So we try to avoid as much as we can monitor anesthesia cases. But if we have to do some, we just ask the patient to wear a mask. And for regional anesthesia, we also ask the patient to wear a mask during all procedures, the time entering the OR, the time we do the block, and during the surgery, of course, he or she is wearing. And we do the block, especially for the block that are close to the mouth or the nose. So like, for example, an axillary block, we kind of put a drape between us and the patient to have one more layer of protection, even if, to be honest, I don't know if this is really useful. But so we put one more drape between us and the patient when we do the block.
Okay, great. And can you remind us how many cases of patient to clinician transmission have there been at your hospital?
None that I am aware of. None, I think. None, okay. None, but I don't think we cannot draw. I think we cannot draw any conclusion from this. Are we lucky, or is it because of our protocol, or is it because we are in Brittany and, as it's been said before, the virus has not been circulating a lot in Brittany? We're not in the east of France or in Paris, so so there's been no contamination, but I don't know if we can draw any conclusion.
One additional question relates to mitigating spread to other people in the room. You mentioned that during intubation and extubation, there are two people in the room, the attending and the nurse anesthetist. Do you have a period of time, a washout period, for the room for the air in the room to exchange, or before additional people are allowed back in?
We make sure that it's us the one who are in the room, who give the signal to the one who are outside so that they can come in, and they only come in when we tell them it's okay. And so we make sure that the patient is on a closed circuit, meaning he's intubated and is on the ventilator, is on the total closed circuit. But our room are under negative pressure, and we didn't take any specific measure to clean out the air.
Okay, great. So with that, thank you very much for all of your answers, and to all of our panelists. There are so many more questions that we can't cover it all in this short period of time, but we actually were managed to answer almost all of them through the online Q&A mechanism. And this does bring us near the end of our CME today. I want to remind those of you tuning in who want to claim CME, you can go to the Stanford website to claim that online. And as for all of our webinars in this series on COVID-19, we will provide an edited recording. We will provide a full transcript, including slides, of this webinar, and we will publish these and make them public. I'm going to hand back to Dr. Kadri for any last remarks here as we're closing the webinar.
Yeah, thank you, Dr. Chu. Actually, there was a couple clinical questions that I think are pretty good. I just wanted to field them. Dr. Alain, one of the questions was talking about the use of LTA on patients during intubation to minimize the chances of cough. Are you doing anything specific to minimize that risk upon extubation?
Minimize the risk of cough, you mean?
Yes, like using lidocaine in the airway, lidocaine spray.
No, we're not actually. No, we're not using anything specific to avoid the patient from coughing. That's why extubation to me is a more dangerous time than intubation. When you use muscle relaxation, intubation is not a very risky time. It's mostly extubation. But no, we don't, and maybe we should use techniques to avoid patients from coughing. But so far, we are not.
We want to thank all the guest speakers who were very gracious with their time in preparing for this and attending this. Just as a reminder, we will be doing another webinar. We don't have the date set at this point, but it's about planning to reopen operating rooms and coming up with strategies about how best to stage the reopening process of operating rooms. That will be, again, through Stanford, the Anesthesia Informatics and Media Lab, and the Learnly program. And with that, I'd like to conclude, and thank you very much.
Thank you, everyone.